First of all, many thanks Agnes for inviting me to join via a webinar. I have a few commentary before going to present something on the Thai experience. The first message is how we ensure increased domestic health spending, which is so critical for achieving USC. And Thailand has increased domestic spending to the level of 77% of THE. And we have demonstrated, and Thailand is at the forefront of USC implementation with good outcome. Second message is that resource tracking for primary health care. I must thank the team who innovate based on data limitation on SHA 2011 with some assumption for which I think all this assumption worth further strengthening and improvement. My hunch tell me that when I was chairing EB 144 negotiation on HLM USC PrEP resolution, for which it would be endorsed by WHO in May this year. One of the content that should appear in the political declaration on USC by September 2019 is that we need resource tracking at primary health care. So that primary health care is one of the key instruments to achieve USC. So this is a few commentary. Thailand has started NHA since 1994 and IGP maintained until even today. And today we have a 15 colleague from Indonesia, NHA team from U of Indonesia, and MOH from Jakarta also join a study visit on NHA disease account. We have finished a disease account for 2014, 15, and 16. We have NASA 2008, 2017. We plan to conduct primary healthcare sub-account as well as TB sub-account because TB is one of the key burden for Thailand. I'd like to spend a few minutes to walk you through how we in Thailand manage UC scheme is generally a general tax finance scheme. Look at Thailand at a glance on the first table. Health spending per capita is 217. As percent of GDP is less than 4, is 3.7%. And look at health expenditure public is 77% of current health spending, and OP has gone down to 11.7%, 12%. And on the right hand side is the low and middle income country average. When WHO produced data on low prevalence of catastrophic health spending and impoverishment, we need to conduct another study in terms of unmet need. If you look at the footnote of table 1, we produce unmet healthcare need of 1.5%, 0.14%, and 0.99% for outpatient, inpatient, and dental care. This is below OECD average of 3.6%. So that means low catastrophic is the real low catastrophic because people has adequate access to health services. So I would urge the WHO colleague in country to look at another side of the coin on catastrophic, which is unmet need. Country having low catastrophic but very high level of unmet need is not good. It's better than catastrophic and save life. Table 2 is USC achievement in terms of SDG 381 and 382. In terms of 382, we have quite low level of catastrophic prevalence incidents, 3.38% in 2010, and now has gone down to 2.1% in 2016. in the graph below. And using national poverty line, the health medical impoverishment is 0.3%, quite similar to when we use international poverty line. A graph has shown graph 1A and 1B, incidence of catastrophic as percent of total household, and also impoverishment has gone down quite significantly, and I will explain why. On paragraph 3, we talk about UC scheme, which is a hard budget and close-end provider payment. As UC scheme is solely financed by general tax through annual budget allocation or negotiation, our initial figure is around $40 per capita, multiplied by 47 million members. This is for very comprehensive, literally zero copay. That's why our OP has gone down very low at 11% of CHE. And now this year, in 2017, the capitation budget is $106 per capita. As it is a hard budget, NHSO cannot overspend or keep reserve and carry over to next year. It must be a zero balance because all this money potential service costs incurred to all healthcare providers in a year, because we use PQ approach, which is unit cost and utilization rate. Hard budget force NHSO to apply close-end provider payment. This results in cost containment and system efficiency gain when compared with fee-for-service payment, for which we have another scheme called Civil Servant Medical Benefit Scheme, also apply fee-for-service, and they spend 4 times as much as UC scheme. Also, NHSO admin cost is very low because they are not responsible to collect premium. All the staff in NHSO is mandated to have better purchase service and better provide financial risk protection to the 47 million members. Admin cost is 1.25% of total UC budget. Now, why public finance UC scheme? We see as an active player in 2001 and advising the health minister and support the team on the reform. I witnessed 3 indicators, 3 major factors. One is political context, second is fiscal context, and third is part dependence. The general election in January 2001, when USC was a political promise in the campaign. So there are 2 choices, whether it's a premium finance for the uninsured 30%, the remaining uninsured 30% of population who are non-poor and they can pay, or we provide them with entitlement to health services using general tax. We find that neither technically feasible nor enforceable to collect premium contribution from the informal sector who has seasonal variation in income. So the only political feasible and technically feasible choice is general tax finance if the government will achieve USC in a year after general election as promised. And the Prime Minister make a decision that go with general tax because this is within his fiscal capacity to mobilize additional resources. On fiscal context, note that 2001 is at the bottom of the economic downturn, financial economic crisis in 1997 in Asia. The GNI per capita is at the bottom if you look at a graph have shown and demonstrate in 2001. Therefore, we cannot afford to apply open-end provider payment, notably a painful experience from CSMBS, which apply fee for service payment, and there are cost escalation, and the per capita expenditure is 4 times higher than UC scheme. Therefore, we don't have any choice except to adopt cross-end payment. Although we have evolution of a mixed provider payment, but the principle of cross-end payment is adhered by NHSO because they have a hard budget. They cannot overspend and they cannot seek for more budget, and they cannot carry over. And every country, Philippines, Indonesia, China, and many countries I have worked with, has always dictated by the historical precedent. Even in India, they are bound by RSBY design of paying for IP surgical costs and negate the majority cost of catastrophic event, which is primary healthcare services, and leave the people alone and pay out of pocket. We have low income scheme launched in 1975. It's fully financed by general tax, and later we cover children under 12, elderly and disabled person. And we have voluntary health insurance launched in 1984 for the informal sector, and it was initially financed by premium contribution, but later in 1994 I submit a cabinet proposal for approval of 50% subsidies, and that trigger set a precedent that we subsidize 50% for the informal sector. And then 2001, when we achieved UC, we fully subsidized the informal sector equally with the poor, the low income. So 100% subsidies for the remaining population who are not government employee and who are not social insurance member. And from the NHA, THE as percent GDP is less than 5%, and we have benchmark that government can spend more, and we spend more effectively by cross-end provider payment. Paragraph 5 is on factor contributing to USC success. For success in 381, which is access to health services, it is the extensive geographical coverage of primary healthcare services. It was reflected by very high level of service coverage. The full geographical coverage of district health system consisting of district hospital and health center is the foundation for pro-poor utilization and pro-poor benefit incidence. This Thailand, we spent 3 decades in investing in primary healthcare throughout the country, and very strong platform for implementing USC with a good outcome. A comprehensive benefit package and literally zero copay and using negative risk approach contribute to SDG 382, which is low level of catastrophic health spending and impoverishment. At the same time, NHSO gradually expand high cost and effective intervention. For example, HPV was launched 3 years ago for every grade 5 young girls throughout the country. We bring down the cost of vaccine by using HTA. The incremental cost effectiveness ratio must be below the benchmark of 1 GNI per QALY, which we trigger decision whether we will adopt or not adopt new intervention. Not only a cost effectiveness ratio, but the budget impact, the long-term budget impact must be within the fiscal space that the country can afford indefinitely. In conclusion, I would say that USC is a real political decision, and window of opportunity open every election seasons. We're going to have election 24th of March this year. Then they talk about UC in the newspaper as well. Second, the tax finance USC is made feasible by cross-end budget and within the fiscal capacity. Therefore, I would say that the Thai experience is not impossible. We can make things possible with evidence and with UC champion like Anson Wong and many others, our predecessor in moving forward. And finally, primary healthcare platform is the must. Indonesia implement UC with a pro-rich outcome because Papua has more services, Java has every services. Then BPJ said everything is covered. It's not true because service is not there. Therefore, implementing USC, premature implementation USC in the light of inequitable geographical distribution of health resources, in particular primary care, can do harm than good. Or in parallel, government should implement and try to provide HSS health system strengthening in parallel with venturist protection for some target population, the most vulnerable population, the poor, the disabled first, and gradually this is a two-pronged approach. Over to you, Agnes. Thank you for your kind attention and have a good deliberation in your 2 days conference.